Hello, assalamu alaikum. Can everyone hear me and see me okay? Is the chat working? Are we ready to start?
Yes, sir.
Assalamu alaikum.
Walaikum assalam, sir. Good
Uh,
afternoon.
are we ready to start, Dr. Rashid?
Yeah.
Okay, perfect.
Okay, sir.
Let me begin then. Okay, great. Welcome everyone to the approach to headache in primary care. Honored to have been invited to teach this on behalf of Bangladesh University of Health Sciences for the postgraduate certificate in family medicine. Thanks again to Dr. Kabir Ahmed Khan for inviting me. So, brief introduction to myself. My name is Mahibur Rahman. I'm a portfolio GP and a consultant in medical education based here in the UK. I'm a fellow of the Royal College of General Practice. So, I've the FRCGP awarded for my work in medical education and humanitarian medicine. I'm one of the authors of the Prescribing Safety Assessment, which is an exam that UK doctors do when they are early on in their careers. And I've been writing and teaching about GP careers, MRCGP and GP, getting into GP training residency here for 18 odd years now. I was an examiner for the General Medical Council for their PLAB exam and an invigilator, and I'm on the NICE GP reference panel. And our team, I work for a company called eMedica. We've trained now over 65,000 delegates in the last 18 years. This is me in where I work as a GP in a secure unit for women with significant mental health. And this is where I was teaching a course with the Royal College of General Practitioners. So in terms of program today, we're going to look at the approach to data gathering for key conditions in terms of what things should we ask about in history, what things should we think about in examination when someone presents with headache, because headache can be caused by so many different things. And then I'm going to go into detail into the guidelines on how to take a history and manage migraine in depth, because that's something that often, because of chronic condition, and it can significantly impact someone's ability to do their job, to function. I want to cover that in depth. Then we'll do an interactive case where I will pretend to be a patient and I will ask you guys to ask me questions as if you're the doctor in the clinic seeing me, and I will give you answers according to your questions. And then hopefully we can work out what could be going on and how do we manage it from there. Finally, we'll finish with a quiz just to make sure that you've taken on board some of the things that we've covered. We'll do a quiz looking at sort of MRCGP style questions covering different headache conditions and their management and diagnosis. And there'll be an opportunity to ask questions at the end. Okay, so you'll be able to ask questions by just typing it into the chat, or those of you that have a microphone enabled, you could use your microphone. Okay, bit of background before we go into that, in terms of how I came to be involved in this program, is that I was born in Bangladesh. I'm originally from a little village called Betauka in Sunamganj, Jagannathpur. And last time that I was in Bangladesh, about last year, I think it was last August, I met with Dr. Kabir Ahmed Khan and saw his wonderful setup at Prava Health. And he was just telling me about this program and so invited me to join. So that's the program. Any questions before we begin? No? Okay, let's start then. Okay, so, no? Okay. So first thing is, someone comes, and it's a really common thing, isn't it? That you'll see a patient in clinic and they say to you, you've asked, what's the problem or how can I help today? What would you like to talk about? And they say, I've got a headache. So some of the first things that we need to think about is, when did it start? So, if someone's had headache for years, for example, that's going to be a different approach to if they said that it just came on today, and the severity. So, if someone's got a new onset, very severe headache, it's come out of the blue, then what we might be thinking about in terms of our differential might be different to someone that's had a headache that's of mild severity, and they get it every so often when they're stressed or in certain circumstances. again, the duration. So things like migraines will usually last hours to days, whereas a tension headache might only last half an hour. It might last much longer. All right. The location, where is it? So again, that can be a useful clue. Tension headache is typically bilateral. Migraine is almost always in adults unilateral. In children, it's usually bilateral. All right. If someone has got, if it's an older patient and they've got it sort of specifically that they point somewhere like here or the other side, especially if they tell you that when they comb their hair it hurts, what might you be thinking about? Try to get involved in the chat. What kinds of things might we be thinking about then? We might be thinking about temporal arteritis or giant cell arteritis, right? The frequency. How often is it coming? Is there a pattern? Is it always at exactly the same time? Is it at any time? Is it related to certain things? Does it come when they have missed a meal? Does it come when they don't get enough sleep? Does it come when they have eaten certain foods? Does it come when they're under stress? What makes it better? Migraine, typically, if someone lies down in a dark room and just rests, over time, it might start helping. What painkillers have they tried? That could be a clue if that's helped or not. The characteristic of the pain. Is it achy? Is it sharp? Is it come in a wave of pain? And then do they have any other associated symptoms either before, during, or after the headache? So with migraine, some patients might have migraine with an aura, for example, so that before it comes, sometimes they get this sense that something's coming. Sometimes they might get a tingling. Sometimes people will have sort of some changes in their vision, for example, blurred vision. They might feel sick. They might vomit. They might find that any kind of noise they're very sensitive to. They might have autonomic or neurological features. Okay, so those are some of the really important questions. And the thing with headache, there's lots of differentials, but in working out what's the likely cause and narrowing down your differential, I'd say about 90% of that is down to history. Taking a good history, asking the right questions, you already would have a very, very good idea. Then examination will help you get to the rest of the way. Okay. So type into the chat, what kinds of things you've taken a history, what kind of things might be relevant to examine in someone that's come with headache? Can you guys use the chat? Or you can use your microphone? Try to be involved. I'm trying to make it an interactive session. Anybody? Nobody. Okay. All right. We'll discuss it then. So first things, you've got the patient in clinic. Check their blood pressure. So if someone's blood pressure is significantly raised, that can cause headache, but it also goes the other way. If someone's in a lot of pain because of their headache, that can affect their blood pressure. All right. If someone's got very raised high blood pressure, then some of the other things that you might want to do is check the back of their eyes, do a fundoscopy to look for things like papilledema. If they're an older patient, you might want to specifically palpate to see if there's tenderness along the root of the temporal artery. A neurological examination. Sometimes people might present with a headache, and it might be the early parts of a stroke or a TIA. Examining the neck to see if they've got any tenderness or stiffness, or any limitation to the movements of the neck. Okay, that can be useful. And then if we look at, you're in clinic, you see some patients with headache, and there's some where you will have some concerns that they need to go to the hospital, that you need to refer them on. It's something beyond what we can manage in a clinic setting in the community in primary care. So these are sort of like the most urgent things, right? So again, most of that will come from the history. So try to be involved with this. If someone's had a history that they fell and banged their head, so they've got some kind of trauma, and then they've got reduced consciousness, so their Glasgow Coma Scale is lowered, they're, can give you some answers, but they're not orientated. They maybe seem a little bit drowsy, maybe their speech is a little bit off, or they have some neurological deficit when you actually do cranial nerve examination, what kinds of things might you be thinking about? So they've got a headache, and these are some of the things that you find out in the history, that it started after they fell or banged their head in some way, and they've got a reduced level of consciousness. What might you be thinking about? Doctors, are you able to use the chat or use your microphone? Feel free to get involved, please.
So this is due to trauma, and there is neurological involvement.
Okay, but what do you think the diagnosis might be? We're going to send this patient to hospital because of this history, but what could be the diagnosis? What should be like high on your list?
There might be a fracture of the skull. Might be injury to the brain matter, or the epidural or subdural.
Yeah, specifically, what would be worried about is secondary to that trauma. What's causing that impaired consciousness is a build-up of a hematoma. So an epidural or subdural, you can see that's why they've got that neurological deficit, because something's pressing on the brain. That's what we'd be worried about. And that's why they need to go to hospital, because they might need to have that relieved. Okay. What about someone who previously had no history of neurological impairment, might be a young patient even, and they got a headache that's come on, new headache, alongside sudden onset neurological impairment. So maybe they've got a weakness or slurred speech or something alongside that headache. What would be, again, high on your list there? No history of trauma this time.
That also might be due to internal hemorrhage, the stroke.
Okay, great.
Something like that.
Yeah, so we'd be thinking about maybe
But those young patients,
a stroke or a mini stroke, right? Because there isn't a trauma there, but like you said, the fact that it's come on quickly. Now, if it resolves within 24 hours on its own, then it's a mini stroke, a TIA. If there's impairment beyond 24 hours, then that's a stroke. But again, these are things that need to be seen quickly, right? Especially if it's a stroke. Okay, what about, oh, that one I've already put the answer there. If they've got very high intensity and sudden onset pain, the classical description that a patient gives is that it's like someone smacked me on the back of the head with a cricket bat. Okay, very, very severe. Even if they don't have depressed consciousness or neurological impairment, if someone doesn't have a history of headache in the past, very high intensity, and it came on very suddenly, we should be thinking about subarachnoid hemorrhage. And again, that needs to go in. Okay, other ones where would be thinking about and concerned about something that needs to be seen in hospital. So alongside headache, they've got a high temperature. Their consciousness is reduced. They've got some stiffness of the neck. That's one of the reasons why we're examining, right? So, doing some of the neck movements, they find it difficult, and they're scared of the photophobia. So the light makes it worse. What's going to be near the top of your list?
Meningitis.
Yeah, absolutely. Yeah. We'll be thinking about meningitis or encephalitis, so some kind of intracranial infection, right? Yeah, excellent. Okay, what about alongside headache? They've got pain in one eye. That eye is red. There's a dilation to the pupil, and it's in a fixed position. They may have a haziness to the cornea. Their vision may be slightly reduced compared to normal. What are we going to be thinking about?
This might be glaucoma, or internal hemorrhage inside the eye.
Okay. Let's expand on that. So if you think it might be glaucoma, can you expand what type of glaucoma?
This is angle closer glaucoma.
Yeah, great, because open angle usually doesn't cause the pain, and it's usually a lot more gradual, right? So yeah, we'll be thinking about acute closed angle glaucoma, which again is an emergency. They need to be seen, right? Good, okay. Then we've got things that they might not need to go to hospital straight away. They might not need an admission, but they probably need to be seen quite urgently for further investigation. So other serious but maybe less acute causes. So if they've got tenderness over the temporal artery alongside headache, we already talked about this, what's going to be at the top of your list, especially if they're older patient, maybe they're 60, 65, that kind of age, anything over 50. Those that haven't been involved yet, try to get involved. You can use the chat or you can use your microphone. Anybody? We already talked about this earlier today, so you should all know this one. Don't be scared to be involved. That's how we're going to learn. Is the chat even working?
Sir, is it due to migraine?
Well, if they've got, typically migraine wouldn't cause tenderness over the temporal artery. It would be on one side, but normally on examination, it doesn't cause tenderness. If you've got tenderness over the temporal artery on either side, usually only on one side, but whether it's the left or right, especially in older patients, what should be at the top of your list is temporal arteritis, also known as giant cell arteritis. Okay. What about someone with headache and when you examine, the fundoscopy shows papilledema on both sides. They're vomiting, especially in the mornings. It's so severe, it wakes them up from their sleep. And it's posture related in that if they sort of bend down their head, it makes the pain worse in their headache. What we're going to be thinking about. I heard something there, but I couldn't hear it clearly. Could you say again?
No, sir, I cannot.
Anyone else? Dr. Murshid, Dr. Hasi, Dr. Zohin, Dr. Kamrun, Dr. Shamin, Dr. Sanjeev and Dr. Rashid have been involved already. Dr. Shahid, Dr. Masood. Don't be scared to be involved. This is how we're going to learn, everyone. If you don't want to use the microphone, you can use the chat. Okay, yeah. So someone suggested, could it be Meniere's? So Meniere's wouldn't cause papilledema. Meniere's can be posture related, and it can cause vomiting, but it wouldn't cause papilledema. Especially, I mentioned it bilateral. What you should be thinking about is a space occupying lesion. Okay, so a brain tumor or something like that will cause bilateral papilledema. And that's why, because of that space occupying lesion, you get intracranial hypertension. So that's why it's posture related, and they'll often get that vomiting in the morning. All right. What about if alongside headache, they've got nausea and their concentration is reduced? What should we be thinking about?
This could be due to migraine.
Yeah,
So
great. So
vestibular.
that could be, but this bit's important. The impaired concentration. So migraine can cause difficulty to concentrate because of the pain, and it can cause nausea and or vomiting. But this one's quite subtle. So if someone's got carbon monoxide poisoning, there's a subtle one that you don't want to miss, where sometimes it can have an impact. And especially, if people have got using gas in an enclosed environment, they haven't got adequate ventilation, which can sometimes happen. So, someone working in a small workshop or something like that, and they haven't got good ventilation, and it builds up over time, then that's something to have on your mind. You're right that migraine can also cause these symptoms, okay? And then we've got the things that we can mostly manage ourselves in the community setting, in primary care, in our clinics, okay? So if they've got bilateral headache, and it could affect mostly the head, but sometimes they might also say that it goes into parts of the face. Sometimes they might say there's a tightening in the neck. They might describe it as a pressing pain, okay? And there may be tenderness, there may not be, and lasting at least half an hour, but sometimes they say it could last like days. Then what we'll be thinking about? Common things are common. Anybody?
It's due to sinusitis.
You might think that if they also had coryzal symptoms, if they also had like a runny nose, feeling blocked up, got like a cold or something like that, maybe. But this is basically the most common cause of headache, right? It's most likely to be tension headache. The fact that it's bilateral, and very classically people describe it as a tightening or a pressing, and it can last a long time, okay? If someone just had sinusitis, for example, it's unlikely to clear up so quickly. And then this one, so unilateral, and they'll describe the pain as throbbing, usually associated with nausea or vomiting or both, and may have photophobia or phonophobia or both.
This is migraine.
Yes, perfect. Yeah, this is migraine. Okay, good. Okay, so now do you see all of these different conditions that we've talked about? The majority of the sort of clinchers, the things that are going to help you separate one from the other and say it's likely to, is to do with the description, is to do with the history, how it came on, rather than examination findings. There's only a few where examination findings are going to make a difference, but you've already got a good idea. You've already narrowed it down. And then that examination gives you the last bit, okay? Okay, so let's talk through how to approach a patient that comes and you suspect that they might have migraine. What are the things we should be looking for in the history? What things should we be examining? What are the criteria to diagnose it? What are the first line, second line management? How does the management differ if they're a child compared to if they're an adult? And so on, okay? So the first thing, in terms of the data gathering, so your history, your examination, you want to ask about localization, all right? Is it on one side? Is it on both sides? Is there a specific point where they feel the pain worse? How long does it last? How often do they get attacks? Is this the first time they've ever had it? Did they describe having something similar but not seeing a doctor before, maybe a few months ago, maybe a year ago? In a lot of cases, because of the chronic and episodic nature of migraine, what you'll find is by the time they come to see you, often they've had some similar things before, but just gone and bought some painkillers and tried to deal with it locally, okay? The nature of the pain, how severe is it? Do they have that association with feeling sick or being sick? How does the light affect it? How does sound affect it? Have they noticed, if they've had it more than once, that there's certain things that trigger it? So for example, they might say the last time they had this, they had a really stressful period in their job. They were staying late and working long hours, and that stress might have triggered it. Or that the last time they had it, they hadn't had much sleep because they had to travel somewhere, they had to get up very early in the morning, and they only got 3 or 4 hours of sleep. And maybe it's the lack of sleep that's triggered it. Maybe normally they exercise, but they've not been able to because they've been unwell in some way. In some cases, it might be because they weren't eating on time, or sometimes it could be eating certain foods. Some people find, for example, with migraine, that cheese sets it off. Other people, it might be chocolate that sets it off. Some people, caffeine can set it off. So it might be certain foods. Then you want to look at how is it impacting their life. Often by the time they come to us as doctors, it's because it's starting to affect their job, or it's got so bad that they're missing days off work. And so that's why they want to get something done about it. And then what have they tried? Usually people will have tried simple painkillers like paracetamol, ibuprofen, over the counter, okay? So to diagnose migraine without aura, i.e. the more common type of migraine, these are some of the things that we look for. So that they have recurrent episodes, typically lasting anywhere from 4 hours to several days. it will usually be associated with either nausea or vomiting, and then either photophobia or phonophobia or both. These, like for an adult, these are almost essential. And then you look for at least two of the following as well. So in adults, it's almost always unilateral. In children, migraine is more commonly bilateral, but in adults, it's almost always unilateral, so only one side. But they'll describe it as throbbing or pulsating when that pain comes, okay, like this. That it will be moderate to severe. So a good way to do that is to ask them to give a number. If you had to put a number to this pain, 0 is no pain, 10 is the worst pain in your life. You know, with tension type headaches, people will often describe it as a 3 or a 4. With migraines, typically it's going to be somewhere from 6 to 10. And then once they have the migraine, remember, it can last anywhere from 4 hours to a day, 2 days, 3 days. During that period, what they'll find is that even just walking up the stairs, normal routine physical activity makes it a bit worse. Okay, these are typical features that we might look for. Other things is that before, so migraine with aura, alongside those things, what you're looking for is that before the actual headache starts, before the migraine starts, that they have changes that are either visual or sensory. So sometimes they like see dots or blurred vision or double vision, or they have dysphasia. They find that they can't say some of their words properly. Okay. And then that comes on gradually, but it normally gets better within about an hour. And by the time the headache starts, it's already settling. So some of the other visual symptoms, they might get flickering lights, spots, they might see lines, they might actually have a partial slight reduction in vision, but again, that's temporary, okay? And sometimes they'll have sensory symptoms like pins and needles or numbness around here before it starts. And a lot of patients have a very reliable aura. So like they know exactly what it feels like. If that comes, they know within an hour, they're definitely going to get a really bad headache. And so they can take their analgesia, they can take their treatment early on, okay? So in terms of management, the latest guidelines from NICE, for adults, they recommend combination therapy as first line because it's more effective. And the cornerstone of the combination therapy is an oral triptan. You can add to that either an NSAID, like ibuprofen, diclofenac, that kind of thing, or paracetamol. But the heart is a triptan. So, for example, sumatriptan could be 50 or 100 milligrams. Other alternatives are there, zolmitriptan, naratriptan, rizatriptan. What you shouldn't use are ergotamines, which used to be used many years ago in the old guidelines, and opioids. So sometimes people buy this, don't they? People can just go to a pharmacy and buy things like codeine. They're not recommended for migraine. In fact, in some cases, people get addicted to opioids, and then it can lead to medication overuse where they're using so many painkillers so often, it actually triggers the pain sensors and causes the pain. Okay, so opioids aren't recommended in the management of migraine at all. Now, we should also consider an antiemetic. So metoclopramide, domperidone, prochlorperazine, even if they don't have nausea or vomiting, it can still help. It can sometimes help prevent it coming on. And anyone that's on a triptan, you know, if you see them and you think it's migraine and you give them this to try, you should arrange a follow-up to see how they got on with it. Okay. And then some patients, when they get migraine, because their vomiting is so severe, they can't take the oral triptans because they just vomit it up, and so it's not going to actually work. So we do have availability of non-oral triptans. So zolmitriptan is a nasal spray. Sumatriptan can be given as an injection. And you also have options of non-oral NSAID. So like diclofenac can be given as a suppository. Similarly, in terms of antiemetics, domperidone is available as a suppository. You have buccal prochlorperazine available, so they just put it under the tongue, okay? And then some patients, they might specifically want monotherapy. So you could just give an oral triptan on its own or just NSAID, or you can use high-dose aspirin in adults, so 900 milligrams, okay? You could use just paracetamol, but that's very rarely effective on its own. It's more usual to add that on as a secondary treatment. In children, so children that have migraine, the first line would be just a simple analgesia, either paracetamol on its own or NSAID on its own. If that doesn't work, then nasal triptans are preferred in children 12 to 17 rather than oral. The research suggests that it works better in this age group. And if we're going to give them an antiemetic, you shouldn't give metoclopramide. Anyone know why? What's the side effect you can get with metoclopramide? Why we avoid it in adolescents? We also sometimes see this in older patients, and why it's also not recommended in sort of patients 65 plus. Anyone know? Someone said something there. I didn't quite hear you. Could you repeat it? So they can cause extrapyramidal symptoms. And so, if you had a teenager and they got migraine and they're nauseous or they're being sick, you still want to give them an antiemetic, but just avoid metoclopramide. You can give them prochlorperazine. That's okay in a teenager, for example. Something else. If someone's under 16, aspirin is not an option for them. Why? What's the risk of aspirin in under 16s? Why don't we use it? Why should we avoid it? Rare but very serious complication. It can be fatal.
So bleeding disorder?
Not a bleeding disorder. I mean, although aspirin can cause bleeding, someone under 16 would be particularly high risk for that, especially for a few doses. It's because of Ray's syndrome. Okay, so there's a risk of Ray's syndrome in under 16s. This isn't something that we see in adults. That's why for adults, it is an option if they want monotherapy to give high dose aspirin. Okay, so let's do an interactive case. All right, now for this to work, I really need all of you to get involved. All right, so the way it's going to work is that I'm going to be the patient, okay? And I'm going to ask you to either turn your microphone on and ask me the question as if you're seeing me in clinic. By the way, if you want to turn your video on and ask me, that's fine too, okay? Or you can type it into the chat and I will respond as the patient, all right? So this is the background that you know about me, all right? My name is Mahibur Rahman. I'm 44 years old. I'm a patient that is known to have migraine, and I have been prescribed sumatriptan to just take for acute attacks. Okay, so that's the scenario. Just 1 second. Let me just stop the share for 1 second. Good. Okay, so let's get started. In fact, I wonder if I can get each person to be involved individually. Why don't we do that? That's because some of you are happy to be involved. Some of you are just sitting there and you're not getting involved. So let's get people involved one at a time. So I'm just going to go in the order that I have on my list. So Dr. Masoom, if I ask you to unmute, you're going to start us off. Okay, so I've just come into your clinic. I've booked an appointment. You start. Dr. Masoom, are you still there? Dr. Masoom? You were there before because you typed in the chat? Okay, Dr. Masoom seems to have left the building. Let's move on to Dr. Shaheen. Dr. Shaheen, if you'd like to start us off. So I'm the patient. You're the doctor in clinic.
Yes, sir. Dr. Shahid.
Yes, Dr. Shaheen. So you're the doctor. I'm the patient, okay? Let's begin the consultation. I've just come in, okay? Assalamu alaikum, doctor.
সালাম কি সমস্যা নিয়ে এসেছেন?
Shall we do it in English?
Okay, sir.
Yeah.
What's your problem, please? Would you
Oh.
please tell me your problem, why you come to visit me?
Yeah, doctor, I've had these migraines for a long time, but they're just getting worse.
When your migraine attack began at morning or any time, would you please mention the time?
It can happen at different times. So sometimes I'll have it in the mornings, sometimes
Whether associated nausea or vomiting?
So yeah, whenever I get it, I always feel sick. I don't actually throw up, but I really feel sick.
Actually, who is remedy? Who is can cause your remedy? Whether any medication?
So yeah, because I saw a doctor before, he gave me this tablet called sumatriptan. So I take that as soon as the headache starts. I take it. But it's getting worse, doctor.
Okay.
Okay. Thank you, Dr. Shaheen. I'll ask Dr. Masoom to take over now. So Dr. Masoom, if you can, are you back? Dr. Masoom? No. Okay. Let's ask Dr. Mujahid to take over. So Dr. Mujahid, you're going to take over now.
Okay, sir.
So
Okay.
Dr. Shaheen asked some very good questions. He asked, how long have I been having these? When does it come? What's their pattern?
Okay.
And what tablets do I take? So I've said that I have this sumatriptan. I take it
For
when it
epilepsy.
starts. But doctor, it's getting worse. So let's carry on from there.
Okay. So then I have to then you the patient, the doctor. So I have to ensure that this drug is not actually working with you. So I have to give something combination to prevent this attack. So with 415, so with 415, I can prescribe you any kind of paracetamol or painkillers.
So doctor, it's getting worse, and I'm taking. I take it as soon as it starts, and then if it hasn't cleared it, I'll take another dose. But I just feel I'm getting more of them, and it's not working. So I don't know if I need something stronger, or I don't know what's going on, doctor, because it's really having an effect on me now.
Okay. So so how can I help you? So what do you want from me that I can relieve your pain? Or
I want these headaches to stop, doctor. So I want either some stronger medication or something that's going to stop me getting them, because it's starting to affect me in lots of different ways.
Oh, okay. So this medicines not only can give you this relief, you have to follow some rules that you have to avoid the sunlight or some crowded place or dirty places that may aggravate your condition.
Doctor, I do all of that. So as soon as I get it, I take my tablet, I just go in a quiet room, I close the curtains and just lie down. But you see, I'm getting so many of these. If I do that, I'm missing work. So I'm worried my boss might sack me.
Okay.
Thank you, Dr. Masoom. I'll get someone else to get involved now. So maybe if you can have Dr. Hasib, would you like to take over?
Sir, I'm not doctor. I'm from IT, sir. Thank you.
Oh, I see. Okay. No problem. How about Dr. Sanjeev? Would you like to take over?
Yes, sir. Sir, you are experiencing this type of pain for a long time. Do you have any family history? Other members of your family are suffering this kind of problem?
Actually, my dad used to get migraines for many years. Unfortunately, he's no longer with us, but he did used to get migraines.
Okay. Rather than noise or other sunlight, do you have you noticed any food that might increase your pain?
So I found for me, if I have dairy, so especially cheese, if I have cheese, I
Okay.
get really bad attacks. So I try not to have any cheese. Also, some dairy type desserts. So like unfortunately, Rosh Malai sets it off for me, which is a shame because that's my favorite. So I stopped taking it.
Okay. Okay. So in that case, you should be very cautious about avoiding this food.
Doctor, I'm very strict about that because I've had this headache for so many years now. But as I
Yes,
said,
yes.
the main concern is it's getting much worse now and it's starting to affect my work. I'm getting so many attacks that I'm, having to miss days from work. And so I'm worried that if I can't fix it and I can't actually work, my boss will sack me.
Okay. What job do you do?
I work in an office as an accountant.
Is that a very strenuous job for you?
It's not strenuous, but it's stressful. So, like, I sit at a computer and I'm looking at different people's accounts. So it's not like physical, but it's quite stressful because we have a lot of clients and, the bosses always want everything done yesterday. So they're always pressuring us to get things done quickly. But then, like, if I've got a headache, I can't concentrate. Even looking at the screen sometimes makes it worse. So I can't really do my job. So then when I've missed, say, half a day or missed one day, then when I come back, but I still got those accounts to finish. So then I have to stay late. So then I miss my meal sometimes, and then that makes it worse.
What about your rest? What time, how much you do sleep in 24 hours?
So I think I sleep a good amount. I probably sleep, I go to bed about 11 o'clock and I wake up 6 o'clock.
Okay.
And
Okay.
once I'm in bed, I sleep. So, but it's when
So
I've
do
got a really bad migraine, I'm lying
okay.
down, but I can't really sleep because of the headache.
Mhm.
So we need to do something about this pain. Okay, thank you, doctor. I'll ask Dr. Sharmin to take over.
Hello, sir. Assalamualaikum.
Walaikum
I'm
assalam.
very sorry, sir. Because of my network, I can't hear you properly. The lecture, I can't hear. Most
I
of
see.
your lecture is interrupting, so it'll be tough for me to take over.
Okay, no problem. If you want to type some questions that you would like to ask me as a patient, you can use the chat.
Yeah, sure, sir. Yeah,
Okay,
I
no
will,
problem.
sir.
Okay,
Thank you so much, sir.
that's okay. How about Dr. Kamrun?
Hello, sir. Assalamualaikum.
Walaikum assalam.
Sir,
So, doctor,
I
can
would
you
like
help
to
me with these
ask
headaches?
to the patient, did you have good sleep, sound sleep every day?
I think generally yes, but sometimes if I've got a really bad headache, it makes it difficult to sleep comfortably because I've taken the painkillers. If it hasn't worked, I can't sleep until I have to take another dose. So that is a bit of a problem sometimes.
And the stress you are taking every day, it's a stressful condition, that your boss might be scold you or sack you from the job. And I think this kind of tension hammering you to overcome this situation.
Yeah,
You need some rest and mental peace.
Oh, that would be nice, doctor, but I still got to pay my rent. I got to pay my children's school fees. It's very expensive. So, I can't just not work. If I don't work for this boss, I still will need to find another boss. And, it's better sometimes, at least I know this company and I know the work here. If I try and look for a job somewhere else, I've got to start from scratch. The main thing I need help with, doctor, is I don't know if you can give me, I don't know, stronger tablets or something to stop it coming. I just need help. I don't want to have these headaches so much. Okay, thank you. Let's see.
Thank you.
Who else has not been involved so far? So someone's asked a question in the chat, Dr. Mujahid, that have you shared this problem with your boss? The thing is, he knows that I have these headaches. And of course, I have to tell him, oh, boss, I can't come into work today because I've got a really bad headache. But I understand from his perspective, he's trying to run a business. If I keep missing so many days, and as I mentioned, it's getting worse in the last few months, I'm getting more headaches, I'm missing time off work, then I understand from his perspective, he needs the work done. So he's, supported me in that he's not sacked me yet, but ideally what I need is for me not to get the headaches as much. I appreciate migraine isn't something that just goes away, but at least if we can reduce the number of attacks, that would be helpful. So I don't know if there's something you can do for me for that. Okay. So can I just ask, who hasn't had a go yet? Can you use the raise hand feature or just let me know so I can get you involved?
So besides sumatriptan, I am prescribing you some other drugs like antiemetic drugs and some anxiolytic drugs. I think only sumatriptan is not working for you. So take these drugs and please visit me after 1 week.
Okay. Will this make me have less attacks, doctor? Will it make the pain less severe? Will it make it better?
I think the anxiolytic drugs and the antiemetic drugs will make you feel better.
Okay. And someone suggested at least I need vacation for some days. Well, the thing is, I've already had time off. So if I now also ask for vacation, definitely going to give me the sack. Okay. So that will make me even more under tension, doctor. Okay, good. So let's stop there and let's have a look at some of the things that maybe you could get a bit more detail in. So you've asked some really good questions, but there's some other things that would be useful if you're trying to build a picture. So for example, as a patient, I mentioned some clues. I said, it's getting worse. So you want to clarify that. Is it getting worse? Do I mean that when I get the attacks, it's more severe than before, i.e. the pain is at a higher severity? Do I mean I'm getting more attacks? In which case you need the detail. So how many attacks am I getting in a month, for example, in the last couple of months? Am I getting attacked every week? Is it more than once a week? Is it, and when I get the attacks, is it worse because it's lasting longer? Let's say someone previously had a migraine that used to last half a day, but now when it comes, it lasts 2 days. That's one way it could be getting worse, right? If someone was previously getting 1 or 2 attacks a month, now they're getting 1 attack every week, so they're getting 4 attacks every month, that could be worse. If someone previously had an attack that when they got their migraine, it was 6 out of 10, but now it's 9 out of 10, that could be what worse means. You see, I'm getting these headaches and it's getting worse. It can mean multiple things. So it's really important we clarify because the detail is important. Similarly, we want to know about the details of how often am I using the medication? Apart from sumatriptan, did I also buy something from the pharmacy? So the doctor gave me sumatriptan, but patients can just go and get ibuprofen, diclofenac. In Bangladesh, they can buy a lot of other things that maybe like in the UK we would need a prescription for. Patients can just buy it as long as they know the name of the drug, right? So getting that detail, what else have they tried? That would be important, right? Okay, so let's just recap. In terms of the history of the headache, we want to know the severity, the character, the position. We got all of that, okay? The radiation, has anything changed about this headache? Is it go always on the same side? Does it go somewhere else? Does it go to the back, for example? When it comes, how long is it lasting? Has it changed in its nature? So let's say someone previously didn't have an aura, now they get an aura. That's interesting to us, okay? We did look at the triggers. Maybe the fact that they're under stress might be setting it off. And then, what do? They go in a dark room, they take their triptan, but it's not working. We looked at some of the predisposing factors. So stress, depression, anxiety, lack of sleep, changes in diet. Again, we asked about this. Any trauma? Didn't have any trauma, but that would be something to ask. And especially depending on someone's job. If someone works in a factory and, for example, something heavy fell on them or something like that, that could cause trauma, right? So that detail will be important. one of the things that's really important is to assess for medication overuse headache. So we want to get a precise number of how many tablets are they taking, how many days per month are they needing some kind of painkiller, how many days in a month are they having the headache. And this is where you also need to get the detail beyond what they're being prescribed. So have they bought anything themselves? So if someone has medication overuse headache, what you're looking for to diagnose that is that they've got a pre-existing headache condition, like migraine, that they're having the headache for at least 15 days in a month. Now, that doesn't mean 15 migraines, because if someone has a migraine that lasts 2 days and they have 8 migraines in a month, i.e. 2 a week, each time it lasts 2 days, can you see that's going to be 16 days a month they've got headache? So you need to get into the detail. So overuse is where for 3 months or more, at least 10 days a month, they're using a triptan. Or if they're using simple analgesics, paracetamol, ibuprofen, things they've put over the counter, 15 days a month, they're using painkillers. And if they meet that threshold, then medication overuse is that they're using so many painkillers that it makes the pain receptors hypersensitive and they start triggering, and the medication's actually causing the headache. So does anyone know how we manage medication overuse headache? Because the management would be very different if we thought someone had a medication overuse. This patient doesn't have that, by the way. If we'd taken the history, you'd see he has headaches for about 10 days a month. And he's using painkillers, whenever he gets it. So because he hasn't reached that threshold of having the headaches for more days than he doesn't have it, 15 days or more, he hasn't reached that threshold. So he hasn't got, but if someone did have medication overuse, the way you manage it is you stop all analgesics, all headache medication, including the triptan, for 1 month to allow the receptors to sort of reset themselves. And then you reintroduce their painkillers one at a time, okay? Now, that can be really difficult because you've got a patient who's got real bad headaches and they've been taking so many painkillers because they're getting so many headaches, and you tell them you need to stop taking any painkillers at all. They're likely to be resistant. This is where you need to explain that the medication's actually causing the headache because it's firing off their pain receptors, okay? So this patient hasn't got that. So what he has got is that, it looks like he's getting headaches more frequently, and there's various factors we've identified. One of the big ones that you all identify is the fact that he's having a lot of stress. So then where do we go from there in terms of management? How will we manage someone who's just getting a lot of headaches and is starting to impact his work, his function? He can't do his job. He's missing days of work. What do we need to think about? Do we increase the triptan? Well, one of the things we need to do is get the detail. When he gets it, he takes it straight away, okay? If it doesn't work, he takes another dose. After that, does it settle it? Yeah, eventually it does, okay? He's already on the top dose of triptan, so increasing the dose isn't going to help. Changing to a different triptan is unlikely to help, because if this eventually does help, that's not likely to change. What we need to think about is, would he benefit from a prophylactic medication? Something to prevent the migraine in the first place. What are the options for that? You can type in the chat. If someone has got to the point where it's starting to affect their function, they're missing work, they're getting more headaches, and we want to reduce the headaches, one thing is what they can do. They can reduce their stress. They can try to do some exercise, make sure they avoid the foods we talked about that trigger it for them, make sure they're getting sleep. All of those are good. But what could we do as doctors in terms of prescribing to prevent migraine? Any thoughts?
So usually in our country, we prescribe pizotifen for prevention of migraine.
Okay, pizotifen. All right. So we'll come back to that. What would you like to examine in this patient then? Before we finish off the management, if we finish off the data gathering, we've taken the history, we've got the history that we've got, he's getting more headaches, it's affecting his work. There are some potential things that are making him get them more often, the additional stress and so on. Is there anything you'd like to examine? Well, you'd want to at least check at the basics, check the blood pressure, check the pulse, have a look in the back of the eyes to see if there's any sort of changes there, right? Okay. So let's say we don't find any changes. So what we've got is increased frequency of migraine that needs prophylaxis because it's starting to affect function. So like you said, in Bangladesh, you might be using pizotifen. In the guidelines here, what we would use is there's 3 options really. So topiramate, propranolol, or amitriptyline. These are the options that we would use for preventative treatment in someone who's getting lots more migraines. And, alongside that, they still continue taking the triptan when they get the acute attack. But the idea of taking something like this, and you wouldn't do all 3, you do one or the other, is that you hope that you reduce the number of attacks, okay? And then the latest guidelines, there is some research to suggest that a dose of vitamin B2 as a supplement can also help to reduce the frequency of migraines. And in terms of follow-up, so if you're going to give someone topiramate, you want to see them a week later. If you're going to give them either a beta blocker or amitriptyline, they take a bit longer to be effective. So seeing them in a week isn't really going to help. You won't be any good indicator of has it actually been effective. You want to see them in 2 or 3 weeks' time to see has it actually helped, has it benefited. Someone else has mentioned a vision test would be important. So yeah, if someone needs glasses or their prescriptions change and they're not wearing glasses, that can sometimes make migraines worse. That can sometimes bring on headaches. So that would be a sensible thing if they haven't had it done. And then the other thing is to think about the way we communicate with our patients, so the interpersonal, exploring. If the patient says, I just want something stronger, why do they think a stronger medication is what's necessary? It is that a different medication is needed to prevent the headache alongside them reducing the things that might be triggering it, okay? But also, like if they really don't want to get it, like if you say, look, can you reduce your stress in your job? If they've discussed it and they're scared about losing their job, they might not want to do that. They might not want, it'd be nice if people could just take a holiday, right? But if they've already missed time of work and they think that, look, if I tell my boss now, I also like a holiday, and they're worried about their job and they don't want to take that option, they have autonomy, right? They have a right to decide that, and we have to respect that. Okay. Right, good. So well done. So the last part of today's session is we've talked about a few different things in terms of what things to ask. We've looked at migraine in detail. We've done a case of migraine that perhaps hasn't just responded and is getting worse and how to prevent it. Now let's bring all of that learning together and add in some other headache-related topics. We're going to do an exam-style quiz. So these are questions I've taken from some of our other courses that we teach, courses for doctors who are doing MRC GP and doing GP entrance exams, okay, for GP training in the UK. So don't worry if some of them are a little bit on the hard side. We learn by doing things that are hard and by making mistakes, okay? So it's a chance for us to revise some of the conditions we've already discussed and just consolidate the knowledge. So what I'm going to do is I'm going to show you a question like this. I'll give you a minute and 15 seconds to think about it. And then I'd like you to type the answer. Let me just see something. Let me see if I can use a poll function. Oh, I can't. Okay, no problem. So what I'll do is, after I give you a chance to look at it, so I'll give you just over a minute, I'll then ask you to type your answers into the chat, okay? And then we'll discuss what the right answer is, all right? So I'll give you... Just gonna put a timer on. You know what, let's make it 1 minute. Makes it easy. Okay, so here's a question, and you've got a minute. Okay. Can you see the timer, by the way? Should be counting down from 1 minute. Okay, feel free to type your answer, A, B, C, D, or E, into the chat. You can only pick one option. So pick what you feel is the most appropriate. There might be other things that you'd like to do, but if you could only pick one, which one? I'll give you a few seconds to put that up. Okay, so we have B, A, C. All right. So let me ask you a question before we get to the management. And this is an example of a two-step question. It's a hard question, okay? Because the question's asking about the next step in management. But for us to know what is the best management, what we want to do is read through this scenario and think, what's the likely diagnosis? All right. So let me ask you that as a question. Type into the chat, what if the question said, what's the likely diagnosis? What would be your thoughts? What do you think the diagnosis is? And then that will lead you to getting what the right management is. It's a very hard question, by the way. So don't worry if you get it wrong. It's going to be one of the things that's going to help us to learn. Okay, so somebody suggested it could be tension headache. Do you agree with that? Do you think it could be something different as a diagnosis? Type in the chat. Okay, someone else has suggested it could be migraine. Okay, no one else has suggested that. So a couple of clues here, all right? This bit's really, really important. So they've had this headache for 2 days now. They're a young patient. It started out of the blue and came on in minutes. It was a very severe and diffuse headache. So it's all over, okay? Not on one side. And then they vomited this morning. So like it started 2 days. They didn't vomit at the beginning. They're vomiting now, all right? That's actually really, really subtle, all right? She's alert, cranial nerves are normal. And then there has been some stress and so on, okay? No neck stiffness, no past history of headaches. This is also important. So what this patient might have, we're not saying they definitely got it, but we have to have it high on our radar and we have to rule it out, is a subarachnoid hemorrhage. And the clues to that are this, that a severe and diffuse headache, that it came on in minutes, comes on very suddenly, peaks within 5 minutes. And why do you think they might be vomiting? Like if someone had migraine, typically they'll vomit early on at the start of the headache or sometimes even before it, okay? Not that they've had it for 2 days and then they vomit. Why might someone vomit in the morning, especially with a subarachnoid? Because it's building up and increasing that pressure, okay? Similarly, migraine would be in an adult unilateral in almost every single situation. It wouldn't be diffuse, just spread out all over. All right. So some of these small, subtle cues. That's why this person, they need to have a CT scan. And I think one of the things sometimes people miss this is that they think that there must always be depressed consciousness. Not always. That sometimes comes later, especially if they've got a small bleed building up, right? But the fact that they've vomited, we have to take that very seriously, especially that it's happened later. And the fact that it came on very quickly, severe and diffuse, that's really, really important. Okay. So subarachnoid hemorrhage. Anyone presenting with sudden onset, severe and unusual, they've never had headache before. Someone known to have headaches, okay, with or without altered consciousness, we cannot just rely on clinical. So even though the examination is normal, the only way you can rule it out absolutely is investigations. The top of that list is CT scan, okay? So, it would need to be dealt with in secondary care. Right, let's do another one. Here we go. I'll put the timer on. There we go. Okay, so that's time. So once again, if you could put what you think the answer is, just one letter, please. You can't pick two options. Otherwise, you could just pick them all, couldn't you? You could put A, B, C, D, E, and one of them would be right, but you've got to pick one. So what's the most suitable treatment? And again, also type into the chat, what do you think the diagnosis is here? The diagnosis, and then the answer to the management in terms of the letter.
Diagnosis is migraine, sir.
Okay, yes, great. Diagnosis is migraine, right? Look, it's unilateral, vomiting, photophobia. They've had different episodes over a period of 3 months, usually last hours, okay? So right now, he's presenting with an acute episode of migraine. It started 3 hours ago. He's had some paracetamol. You can just buy that from any shop, okay? Any pharmacy. So he's got some paracetamol, but it's not helped. So what's the most suitable treatment? This is something very subtle, but very important. It's 15. We talked about some of these things earlier, okay? So we've got options in terms of management of E, A, D, A, D. So the correct answer is E. So well done for all of you that said E. So options we can give, because they're under 16, we don't want to give them metoclopramide because of the risk of extrapyramidal symptoms, okay? We don't want to give them option C because aspirin we don't give to under 16s because of the risk of Ray's syndrome, okay? And then this age group we talked about, if simple analgesia like paracetamol isn't enough, then if we want to add a triptan, it should be nasal, not oral. And if paracetamol, they took it 3 hours ago, they can't take another dose of paracetamol now. So we can add to that ibuprofen. Okay, so that's why E is the best option. And this is something, for those of you that at some point you might be doing some exams later on, that sometimes you can eliminate options because there's something that makes them not suitable. So the fact that he's 15, aspirin straight away, not suitable. Metoclopramide, not suitable. Now, even if you're guessing, you've got 50-50 chance of getting it right, even if you're guessing. But the correct answer is E. Okay, right. So, and in terms of diagnosing migraine, in the UK, we have something called the BASH criteria. This is the British Association for the Study of Headache. So what we say is that you won't say that someone's definitely got migraine. You can say they've got suspected migraine, but you won't diagnose them as having migraine until they've had at least 5 different attacks that fit the typical things that we see in migraine, i.e. they last for hours, to days, that they've got the typical features. So they're unilateral, they're pulsating, they're moderate to severe, they're aggravated by just things like walking or climbing the stairs. Okay. That when they have the headache, they either have nausea or vomiting or both, photophobia, phonophobia, or both. And that we don't find anything else in the history examination that makes us say, okay, this fits with this. For example, if someone had all of these things, but then they've also got neck stiffness on examination and they've got a non-blanching rash, we're not going to say that's migraine because that fits with meningococcal meningitis. Okay. Now, where I've put an asterisk here, 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 it means in children, you don't need these things. So children can sometimes have a migraine lasting an hour. It's usually bilateral in children. Sometimes they don't have nausea or vomiting. In adults, this is what we look for. All right. And in terms of acute management of migraine, I mentioned this earlier, but just to have it as a recap, that for an adult, first line would be a combination of an oral triptan with either an NSAID or paracetamol. For someone 12 to 17, first line would be just paracetamol on its own or NSAID on its own. If that isn't effective, you add in a nasal triptan rather than oral, and then consider adding an oral antiemetic for anyone with migraine, even if they're not being sick. But we don't use metoclopramide in children or elderly. Prochloroprosine would be a better option for them. And then again, aspirin is an alternative to NSAID for adults, but not for under 16s because of Ray's syndrome. Codeine, tramadol, morphine, any opiates, not recommended. Ergotamine, not recommended. Okay, let's do one more. I'll start the timer. Okay, feel free to type your answers in. So A, B, C, D, or E into the chat. Again, we did talk about this earlier, so this is just a revision. It's just a way to consolidate the knowledge while it's still fairly fresh in your mind. So we've got A and B are the two popular options so far. Okay, so the correct answer would be B. So well done. Quite a few of you picked that. That was the most popular answer. So if they're using a triptan 10 days a month, that meets the threshold. But remember, we talked about they've got to have been doing it for at least 3 months before we say it's medication overuse. So because this is 2 months, that's not enough. For aspirin, ibuprofen, paracetamol, for these types of analgesics, it needs to be 15 days a month. That's why these don't meet the threshold. These all meet the threshold of time, but not enough days. Whereas this one, using a triptan for 10 days a month, and it's for 3 months or more, it meets both thresholds. So this is the one that fits medication overuse headache. Okay. Just again, as a recap, how would we manage this patient? By stopping all their analgesics for 1 month. Okay, then reintroduce it. Okay, so medication overuse headache. They've got to have a pre-existing headache disorder. They're having the headache for at least 15 days a month, and they're regularly overusing for at least 3 months. So for triptans or combination treatments, 10 days a month or more. For simple analgesics, NSAIDs, aspirin, 15 days a month or more. Okay. Right, so to summarize, look, headaches are really common presentation in general practice. One of the things that we want to do when we see someone in primary care is to ask the right questions and do the right examination to rule out a serious cause. Because although they're less common, we don't want to miss someone having a stroke. We don't want to miss someone having a subarachnoid. We don't want to miss someone having something that, if they're not seen urgently in hospital, might mean that they come to serious harm, okay? But the majority of people with headaches have things that are chronic diseases or acute problems that we can manage in the community. Now, as part of chronic conditions like migraine, a big part of us managing that to benefit the patient long-term is education. That if they understand what are the things that could be triggering that, and they can avoid them, because a lot of patients, they just take more and more painkillers. They don't think that it could be related to their food or related to taking enough sleep or related to getting finding ways to reduce their stress, maybe doing some exercise or relaxation techniques. And so by taking a good history and you find out what could be setting off in the first place, and then educating the patient about the impact of that, rather than just giving them more painkillers, because that could actually put them at risk of medication overuse headache. That's how we're going to make a bigger impact on chronic conditions like migraine. Okay. Right. So I've got 10 minutes left, which I've built in for questions and answers, really. So anyone got any questions, please ask. And I'll just put this up. If anybody wants to connect with me on social media, feel free. You can always send me a message if you've got any queries. But also I often post sort of like clinical topics, communication skills topics, little videos on our YouTube channel and on social media. So feel free to connect. I'll take a picture of that. But anyone got any questions, feel free to use the chat, or you can turn your microphone and ask. We've got about 10 minutes left before the session's due to end for questions and answers.
Sir, I think there are two more headaches which are commonly presented to us. Those are the headache due to hypertension and headache due to visual stress.
Okay.
Lots of patients come to us with these type of headaches also.
Okay, great. So yes, let's talk about those. So the first one, remember, a lot of patients with high blood pressure, they will have no symptoms. That's why we call it the silent killer. Okay, but one of the common symptoms for those that do have symptoms is that they will get a headache. It's probably one of the most common things that someone comes with a headache, and then that's why one of the essential examinations is blood pressure. Is it might be a way that we pick up that they actually have high blood pressure and we've not picked it up in the first place. So there's two elements to that. So the first element is, in terms of managing the pain that they've got at the moment, is just simple analgesics. So paracetamol, ibuprofen, all right? And they should only take it, the minimum dose that helps, because you don't want them to be taking too much. The second thing is to deal with the cause. So what's causing the headache? If it's high blood pressure, so then we've got to look at managing their high blood pressure. So, if they've got hypertension, if it's at a level of 140/90 or more, and they've got additional risk factors, we probably want to start treating that. So then, depending on their age, depending on if they've got diabetes or not, under 55 generally, or anyone with diabetes, we're going to start them on an ACE inhibitor to manage the high blood pressure. And once the blood pressure normalizes, they should find that their headache improves. So again, educating about that long term, that will help. And then things that can help, general lifestyle things for alongside medication. Because if someone hasn't got lots of other risk factors, you might not start them on medication straight away. What you might suggest is they get to a healthy weight, they do regular exercise, they reduce salt intake. Us Bengalis, we love to add salt, right? A lot of people, Plato Batloya, even Salon Haisonina, they've already put salt like this. They're shaking the salt on already, right? Before they've eaten anything. They don't even know if it's already salty or not. People like to add a lot of salt, but reducing salt, that can help. Doing regular exercise, eating a healthier diet. Those are some of the things that they can do to help. But, if it's significantly raised, medication. So under 55 or diabetic, ACE inhibitor, 55 plus, generally would start them on a calcium channel blocker as first line. Okay, so managing the actual underlying cause, and then you could also look at what might be contributing to raising their blood pressure. So, for example, have they got stresses and things like that? Okay, and then visual related headaches. So, a lot of patients might have visual deficiency, so they might be short-sighted or long-sighted, but they just haven't had an eye test, because a lot of patients, especially in the villages, they don't have an optician nearby. They just haven't had an eye test ever. But if someone's getting a lot of headaches and they're straining and their vision isn't clear, we should check their fundus to see is there anything going on there. But really important is send them to have an eye test. And then if they need glasses, if they understand that having glasses so that your vision is adjusted and you're not straining, because that strain can set off a tension headache. That visual related headaches, usually it's a tension type headache. So again, in terms of until they've had the eye test, in terms of management, that is just simple analgesics, paracetamol, ibuprofen. Nothing more is usually needed than that. But the more important thing is deal with the underlying cause. So get an eye test. If they need glasses, getting the right prescription glasses, and then it should adjust. Like my son, he used to get really bad headaches. And, once we had his eyes tested and he got glasses, and once they were the right prescription, alhamdulillah, it cleared up. But while he had it, of course, it's quite distressing. Okay. So I hope that helps. Any other questions? Okay, well, if you haven't got any other questions, let me know in the chat. Did you find it helpful? Was this a useful way to learn? We talked about the conditions first, then we talked about the principles, then we did an interactive case, then we did a quiz to consolidate knowledge. Was that a useful approach to covering a topic? Did you find it a useful session? Do you think that you've got a clearer approach if you see a patient now who comes to you with headache, to what are the things I want to rule out? What are the things I should be asking? What's the level of detail I need to get? And then once you know what it is, do you feel more confident in how to manage it? Let me know. Always helpful. No? Any other questions? Okay, good. I'm glad you find it helpful, Dr. Sanjeev. So if there are no other questions, we only got 5 minutes left of the session anyway, but I appreciate you've all been to Jummah. I'm going to go to Jummah shortly. So very nice to work with you all and meet you. I hope it's been helpful. Thank you so much. Please do remember me and my parents in your du'as if you found it helpful, okay? Assalamu alaikum. And I hope to meet you. I'm coming to Bangladesh later this year, inshallah. I'm going to come in December. So I hope I might be able to meet some of you when I come, inshallah. Okay? Assalamu alaikum.
Thank you very much.
Thank you, sir.
Wa alaikum salam. You're very welcome.
That's a very nice session. Thank you.
You're welcome. Assalamu alaikum.